Hi guys, I decided to do my paper and presentation over the topic of restraints and seclusions. I feel as though there is quite the stigma about them, as there should be in many cases, but I also wanted to iterate on the fact that they can be life-saving and necessary in certain circumstances. Alright, so according to Pogue et al., a physical restraint involves attempting to guide or control a client by placing one's hands on them. So the use of restraints may include, but are also not limited to, the following means. We have physical, which involves hands-on approach between the client and supportive party. There's mechanical, and that involves the use of straps and belts to secure a patient. And then there's also chemical, which includes the use of tranquilizers and medicines. So, seclusion, on the other hand, is the process of confining a patient to a particular room. It is important to note that whenever patients are taken to a room, no matter if the door is locked or unlocked, it should be considered seclusion. However, when a patient is asked to go to a designated room for the purposes of calming down, this should not be considered seclusion, but rather a form of de-escalation. So, seclusion in many institutional and residential environments involves a locked door confinement within a safe, padded room. Aggression that is often being directed toward oneself and towards others is the most common antecedent behavior that results in the use of these seclusions. So you may be asking yourself, who, when, where, and what for? Well, individuals who are repeatedly aggressive, dangerous, and cannot be maintained safely within the home and community settings are usually placed within residential treatment centers and behavioral health settings. So these measures may be necessitated due to individuals displaying aggressive, harmful, or elopement behaviors. Without seclusion or restraint, there is a higher risk for menacing injuries versus the more short-term injuries that may come from the use of these procedures. So research by Delaney displays that characteristics of those who are most likely to be restrained include those who are male, they have previous psychiatric history, they have a longer length of stay at the residential grounds, and there's a history of SIB. Now, these characters do not necessarily define someone who has to get secluded or restrained, but rather they describe individuals who may have a harder time with self-control and regulating appropriate behaviors in given circumstances. So the use of these types of interventions is commonly used in behavioral health settings. The potential ethical dilemmas that could arise from these types of interventions may include the possibility that they end up actually stimulating more aggression, the fact that they may be associated with increased costs toward the institution, and it may demonstrate a lack of compliance with standards within the legal and clinical settings. So if they have regulations already set in place and you use seclusion or restraint, you could get into big trouble. So Huxhorn, he reviewed 3 ethical issues that may come about in practice given these procedures. There's the issue of restricting the use of restraints and seclusions when in the face of real danger towards staff who rely on these measures to maintain safety. Another issue is related to keeping others free from harm when another's self-control has been confounded from personal discrepancies. This leads us to the third issue, which arises from whether or not the use of these procedures is worth the psychological effects of trauma and potential risk of serious injuries that could happen towards staff and patients if we use them. Ultimately, managing aggression in children and adolescents raises ethical concerns and brings up a conflict between the patient's needs and their legal rights. So, at my current job, we collect frequency behavior data, and from that, we see that nearly every day, at least one client is engaging in an aggressive or elopement behavior that requires the site's use of physical restraint. So at our site, we use crisis prevention intervention, which is CPIs. So with over 20 clients receiving services within this setting, It is important to give all of them an equal chance to a therapeutic and safe environment. This would be a much harder setting to provide if staff and clinicians were unable to restrain our individuals who were acting out. So, common behaviors displayed by my clients involve threats to harm oneself and others, and oftentimes involve the client attempting to use physical aggression against staff peers, and then they usually end up trying to elope. So, without the strain, many individuals could get seriously hurt. Despite the risk of harm towards the client acting out during CPIs, the increased risk these behaviors have on harming others cannot be taken lightly and should be of utmost consideration. So, the Center for Medicare and Medicaid Services, CMS, and Joint Commission is one of the agencies that have set up guidelines. These dictate that these procedures are only to be used when there is an imminent risk to the patient or others. Intervention of this restrictive nature should only be used in the most extreme circumstances, and when they are used, a licensed practitioner must evaluate the individual within an hour. So, checking on the patient within the hour is a preventative measure that ensures a patient who is restrained or secluded has not received any long-term dangerous injuries in the aftermath. So regulations that Kutz found, there are 7 states that place some restriction of the use of restraints, but they do not regulate seclusions. There are 17 states that require selected staff receive training before being permitted to restrain children. There are 13 states that require schools to obtain consent prior to using foreseeable or non-emergency physical restraints, while 19 require parents to be notified after restraints have been used. So, 2 states require an annual reporting on the use of restraints. 8 specifically prohibit the use of prone restraints or restraints that impede a child's ability to breathe. Some relevant court cases due to the improper use of restraints and seclusions are spread far across the states. So within the last 10 to 15 years, many of the cases have been taken to court due to injuries and unfortunate deaths of patients undergoing this treatment. In one such case, a 14-year-old male with a history of disruptive behavior at a residential facility, he died from brain injury due to oxygen deprivation. So his death was a result of being pinned down on the floor using a prone restraint for 20 minutes, which evidently cut off his supply of oxygen. Due to this case, in 2008, Pennsylvania banned the use of prone restraints. Another case involves a male, age 11, diagnosed with autism at a New York residential school and state facility for children with developmental disabilities. The child was subsequently secluded to his room for extended periods in which his access to regular meals were restricted. From this, a law was enacted that allowed parents the full access to records of abuse cases. So, upon an investigation of the states, it appears that Illinois has an extensive list of laws that have been enacted. These pertain to schools, state boards of education, and educational and cultural facilities. The biggest code is the one listed above, which encompasses previous codes already in action. So the codes prohibit the use of physical restraint and seclusion, except when the student imposes a risk to others. There's no medical contradictions, and the staff have been trained on how to properly administer the intervention. They say that restraints are considered a planned technique and shall not be used as a means of punishment. Timeout rooms cannot be locked, cannot be a confining space, and it has to be a room where the client can be observed. The space within the room has to meet specific size requirements. It must be free of harmful agents, and an adult must be within 2 feet of the client at all times. When restraint and seclusion measures have been used, they are to be documented in detail, and the parents are to be notified within a window of 24 hours. There are numerous BACB guidelines in place that assist in keeping ethical conduct in check. In the case of restraint and seclusion, ethical guidelines should guide the behavior of therapists, specifically keeping in mind that those who are trained and call themselves BAs need to continue to conduct themselves in a way that positively reflects the field. Specifically, Guideline 1.01 reminds behavior analysts that decisions they make about and for the consumers must be tied to science in order to give them the best possible therapeutic experience. Part of providing the best treatment is to have a broad and continued scientific knowledge and not be so narrow-minded in thinking. This is important to consider when working with these interventions. Though certain alternatives were proved scientifically valid at one point in time, they may no longer hold the same value. Given the scientific community is continuously growing, BACBs should be aware of these ever-going changes and adhere to them in their practices. Another guideline are 2.0 and 2.03, and they state how the best interests of the client and those parties who will be inadvertently be affected by their services is a main responsibility. On a whole scale, the decisions that behavior analysts make on a day-to-day basis will have an effect on the quality of treatment being provided. So when it comes to the use of seclusion and restraints as an intervention, it is important to keep in mind the types of outcomes that could arise from these restrictive measures. So in order to gain an understanding of the current methods being employed within emergency departments, Downey et al. Randomly sampled 40 institutions using a survey tool containing restraint and seclusion standards. This allowed them to collect current agitation reduction techniques. The results indicated that all the institutes had protocols in place about the use of these interventions and had trained staff about the alternatives to restraints. Despite the protocols and trained staff, 30 to 40% of the institutions still relied on chemical restraints. In another study, a sampling of 105 individuals who had been admitted whose aggression was thought to be a product of psychosis were placed in one of two intervention groups, which included seclusion and restraints. Results displayed that about 2/3 of the seclusion group could be managed with what was considered the lesser restrictive intervention comparatively. And then Miller et al. Had two-phase study. This incorporated a restraint reduction committee and a milieu setting. The results showed that 42 to 52% reduction in the use of seclusion and restraints were a product of this. So there's been a stigma about the field of behavior analysis due to events of the early years that base their treatments on aversive procedures. Being known as a field that provides behavior change contingent on punishment has created a bad light about the work that is actually done. So considering this has been a label that has been attached to BA for some time, any procedure seen as aversive could be an added negative. In light of the topic of seclusion and restraints and behavior analysts' role in using them, there may continue to be the attached stigmas with the field. So in face of making the choice between keeping a client safe by enforcing these techniques versus allowing a large risk of danger, then ethically, the behavior analyst should do what's best for the client. In all cases, the client's safety is going to be of utmost concern. So how should we handle clients with aggressive natures? First, we should develop a plan of strategies for each individual client. This should involve the client. At our current facility, we sit with the client and together identify behaviors, antecedents, and triggers to these behaviors, and then write out suggestions to family and staff that can help them manage their aggressive behaviors. Next, we can predict who has a higher chance of engaging in challenging behaviors, and then allocate resources to helping finding the triggers and calm down strategies. And then last, we can have verbal one-to-one interactions. So staff often have inappropriate conversations with the clients, which could actually lead to a problem. So having trained staff that know how to de-escalate properly using a neutral manner or a calm voice could be beneficial. So as staff in emergency departments are more frequently asked to engage with patients who often display threatening and violent behaviors, the issue of when and how to control the individual will arise. Providers are often caught between their responsibility for patient and staff safety and the use of least restrictive methods to administer treatment. A clear understanding of the effectiveness of procedures currently in place is needed in order to control symptoms enough to treat patients while also balancing the issues. Of completed surveys that were collected from a study conducted by Downey, a panel of experts had determined that emergency intervention was necessary in nearly 1 to 20% of cases of behavior emergencies. There is a lack of discernible research and studies that provide even the slightest hint about where procedures do and do not work best given specific behaviors and age groups, which condones the need for more studies. There is a strong need for evidence-based procedures and guidelines to abide by. The overarching goal for behavioral interventions, given aggressive, dangerous, and eloping behavior, should not be to eliminate restraints and seclusion techniques, rather to gain an understanding of when and how to appropriately utilize them in the face of consumer safety. And here we have our beautiful resources. And here we have some more. And here's our last bit of resources. Thanks, guys.